So I'll just give you like the quick story. So I came to town 22, 23 years ago. Was at the Orthopedic clinic there practicing for about 18 years or so. We sold the clinic to the hospital, and I stuck around for too long, which was about 3 years. Discovered very quickly I was a terrible employee, and they were terrible managers, so it just didn't work out very well. So we just opened up a practice down the road. I mean, down the hallway, essentially. So I'm now just in my own clinic there. I've got 4 providers and just got going in January. So up and going and already busy, and everything's back to where we were before, just without the same headaches. Now I have different headaches. But I spent my whole career in private practice, so it was difficult for me to transition. So I'm glad I'm back in private practice. It's going well. So this is what we are going to talk about a little bit today. In fact, I'll tell a funny story that I just thought about because one of the disc replacement companies made me go learn how to do it, and I talked him into letting me stay here to do it. And so Ken taught me how to do it up at the U. Like, I can't remember who it was. I think it was a disc replacement, but yeah, when you were up there, and it was you and like oh, it was so long ago. Yeah, like a long time ago. Anyway, so we're going to talk a little bit about cervical and lumbar disc replacements. So you guys know this better than I do, but this is a big problem. We just heard about the intercept procedure. Some of the pain docs I've worked with are doing that and having good success, but back pain is a huge problem. So is neck pain. 50 billion spent by consumers, so that's outside of insurance. So it's just a crazy problem. And this is kind of designed for a conversation with everybody. So some of this you'll just scratch your head and wonder why I had to bring it up, and some of it maybe will be new and novel, but that's just a picture of the spine. I think we get it. But everybody gets back pain. The more fit you are, the less likely you are to get it. The more obese you are, the more likely you are to get it. Things like smoking and other things like that contribute to it. So job-related activities, heavy work, bending, lifting, twisting, all those things that we all do every day, especially with poor biomechanics and obesity, things like that, really increase the stress in our discs. And age, of course, it's a big-time age problem. As we age, all of our discs wear out. They just don't have a great blood supply, so they don't heal very well. And so they just become a bigger problem the older we get. And then genetics plays just a massive role in this too. We were part of a study a long time ago that looked into the genetics behind just the diagnosis degenerative disc disease. So everybody that was diagnosed with that got a swab, and there's just some powerful genetics behind this, and all cartilage diseases actually. But so this is it's a complicated situation, and so disc replacements, I think, we're understanding them better. I think it's safe to say that the technology has improved over the years. But I think more than just the technology improvement, it's surgeons' understandings of when it's a good idea and when it's not a good idea. I think there's still a few people out there that push the envelope too much for what I'm comfortable doing. But at the same time, patients really think this is sexy compared to an ACDF. And so I think surgeons get talked into it sometimes when maybe they shouldn't. But at the end of the day, it's a fantastic procedure. It's just not for every single patient. But it is really a great procedure in the right patient. So the reason I say it's complicated is there's just so much stuff in there that could be hurting. And so, if you see somebody with a big juicy disc herniation, they've got radiculopathy and it all correlates, easy, no brainer. But there's a lot of degenerative disease there as well. You really kind of have to figure out what the pain generators are to make sure you're fixing the problem. If you've got horrible facet joints and you do a disc replacement, you'll jack that open, you'll release some of that pressure off the facet joints, but they're still moving and they can still contribute to pain. And so, early on, if you had any degenerative facet arthritis at all, it was like, no. But that indication has gotten much broader now. I think surgeons are more comfortable doing it in degenerative situations. But again, you kind of have to be careful because those facet joints are still going to be moving and they're still going to be causing pain. So you kind of have to be careful. So the workup before getting a disc replacement in my office is a little bit more intense than we would for a simple fusion or something. So, but again, you guys know probably better than I do what all those structures are that can possibly cause pain in the neck or back. So mechanical structural problems, sprains, strains, degenerative disc disease, herniated disc, spondylolisthesis, that I will just say for me is an absolute contraindication if it's any more than just a very, very mild, like cervical grade 1. In the lumbar spine, I won't do it at all with any listhesis. But in the neck, I do a grade 1, very mild listhesis on occasion. So lots of things in the spine that can cause problems. So this is just a really, and again, I want to, like ask questions, call me out on stuff. Let's talk about these things. But this is just a case study, just kind of show you what the perfect, kind of candidate is. So this is somebody that's, you can see their neck is a little kyphotic. It's an MRI scan, so it's not, terribly accurate for those kinds of measurements, but a little kyphotic, a disc herniation there, a little bit of degeneration, not terrible. A little bit of disc out in the foramen. And this is the procedure. So the disc this one here is still one that I use. This is from Sentinel Spine. It's a Pro Disc. They're kind of one of the earlier ones. They've been out there a long time. They've had some minor changes to the disc itself. There's lots of discs out there. And I think they're all pretty comparable. Some are better at some things than other. I used the Moby Cs for a long time. I don't know if you ever use that, Kim, but had great luck with those. Then they started to have some literature coming out of Australia from one of my buddies that kind of made me back off a little bit. So I'm back to using the Pro Disc again. But we've had great luck with this, but there's literally, probably a dozen of them out there now between the cervical and lumbar spine. So, so the procedure is really identical to an ACDF. So I trained with Henry Bowman, who is a famous spine surgeon, and because of that, he convinced us all we had to go off to the left. So my incisions are always from here to the left a little bit, because in the early days, everybody believed that if you stayed on the left side of the neck, the recurrent laryngeal nerve is always in the same place, and it's a little bit safer. It turns out it's always in the same place, but it doesn't make the safety of that recurrent laryngeal nerve any different. And so most people, I would say, go on the right side. I just go on the left because of tradition, because of Henry Bowman. And he was one of the people that kind of was early on in cervical spine surgery, was somebody that developed a lot of stuff, a lot of techniques. He was not an instrument guy, but he would have done that literally with a piece of fibula or something, and machine it perfectly. And you don't need plates. You don't need any of that stuff, because if you do good carpentry, all that's unnecessary. None of us do good enough carpentry to replace implants anymore. So, but kind of an old school thought process that he had. But so that's it placed, and you can see just it does jack open that disc space a little bit. By elevating that height, you get a little bit more clearance out in the foramen, so it decompresses the foramen a little bit. Of course, we're coming in from the front, taking all that disc out, so you can do, reach out and do the foramen from, through the disc space as well and get it cleaned up. And then, rely a little bit on that, jacking that open process. And then you can see the facet joints here, if they're really arthritic, they're still going to be moving. And so that's the one thing that I'm always in the back of my mind focused on, like checking those facets to make sure I'm not going to be, getting rid of a disc herniation and leaving with bad neck pain because those facets are still a problem. And that's just the front view of it. So pretty standard procedure. I personally will do an occasional cash pay, 3-level or something, but the majority of these are indicated for 1 and 2 level constructs. Insurance companies are a pain. There is some good news if you read the newspaper recently, but Blue Cross got sued for, I think they just settled a lawsuit with the government for $2.7 billion, essentially because of them blocking access to healthcare. So for patients. So yeah, but they probably saved $200 billion during the 20 years that they were going through this process. So I think they came out ahead still, but maybe it's good news for us that maybe some of those, getting permission to do a procedure is going to be better. Let's hope.
So Dr. Huntsman, for this procedure, what kind of incision, you said kind of to the left, but are you using like a robot, are you using like a tube?
So for this, I do these just open, but the incision is just, maybe 3 or 4 centimeters, pretty small, especially for a single level like that. the skin here is so floppy that you can do multiple levels through a small incision because you can move it around pretty easy. And then I do a transverse incision the majority of the time. So, it's pretty easy to get up and down to get to the next level. And then really the platysma is there. You cut the platysma and then you don't really have to cut anything else. So you kind of dodge between the other structures and so you're right down on the spine pretty quickly. From a left-sided approach, the tracheoesophagus goes off to the right, and you're looking at the vertebral body and the discs. So it's a pretty straightforward, simple exposure, and it's really not a painful recovery for people. I'd say probably the majority of patients wake up from surgery and actually feel better in the PACU, which is not true of most of my lumbar cases. So those guys don't like me for weeks and sometimes months. So this is just a surgical technique really quick, just so you can kind of see that. Maybe it's going to play. Wi-Fi is
Yeah, you just
bad.
go to the right.
I just imagine this amazing surgery. That is good technique.
You just space bar.
That's how quick it is. It's that
Yeah.
quick. So essentially, the surgical technique is you again off to the left for me, go through the platysma, retract everything else out of the way. I put a Caspar pin, which is just a spike of a pin that goes into the vertebral body, above and below. And then you put a little device over that, a retractor, jack that open, and it just pulls the disc space open so you can work in there a little easier. All this is done under a microscope. I've always used a microscope, and now I'm really grateful I use a microscope because I don't think I could see it as well as maybe I did in the past. So then you're looking right at the disc space. Then we take a lateral x-ray just to verify levels, and then do a complete discectomy. So coming from the front, take out the entire disc. We try to not do a lot of bony work because early on these things, some of the early devices would actually fuse. And so we try to not have a lot of bony bleeding or things like that. So we're careful to just kind of curette the end plates off. I do burr a little bit on occasion when I need to. And then once we've got the disc out, you reach out into the foramen, clean out any disc fragments or whatever's out in those foramen, get that opened up. And then there's several different trial sizes. These come in lots of sizes, which is very helpful, both width, depth, and height. So you can kind of get the right one for the patient. And then the secret to these, it's really more important on some designs than others, but the secret to this too is to get the center of rotation in the right place. So it actually, in some of the disc replacement designs, in a natural neck, the center of rotation, when you flex and extend, changes. It's not in a single point. Most of these are just in a single place, so you try to get that in the right position just for the motion to be better. If you look at some of these under fluoro, it's kind of fun actually, but the Mobi-C that I talked about earlier, if you look at that under fluoro, it moves very naturally, but they were having some other complications. If you look at some of the others, everything kind of moves and then the disc kind of clunks over at the end. So you get the motion, but it's not completely natural, but definitely much better than no motion there at all. And again, some of them are better than others. And then once you've got that, you choose the right size implant, you literally just tap it in and you're done. Close up the wound and go home. That's probably a 30 to 45 minute case. It's all outpatient, so they go home the same day. And really everybody does. We all love neck surgery because everybody does well. So again, not as true of the lumbar spine. So that's kind of the technique. Very straightforward, very simple procedure, very, very safe. I mean, there's a lot of structures up in the neck, but they're easy to avoid, and we don't have a lot of problems with this. When we get into multiple levels, like ACDFs, 4-level ACDF or something, we start worrying about swallowing. We start worrying more about the recurrent laryngeal nerve and some of those complications. But for a single or a 2-level disc replacement, those are pretty darn rare. Really a safe procedure with really great success. Again, if you chose the patient right. And I think that's always the key, right, for anything that we do, is patient selection. So.
How does the data look just from an outcomes perspective? Is it based off percent of relief, or how do they measure that?
For the outcome studies in these? So I was involved in 2 of them, and really the outcome studies early on were all focused on comparing it to ACDF. So you have, two arms, ACDF, disc replacement, compare the two, and the outcomes are everything, relief of radiculopathy, relief of neck pain, functional scores and things. And so it's really kind of all of those things. I think I lost the.
So when you do surgery, how many of those devices do you have standing by?
Oh, they got like a plastic bin, looks like they got it from Costco or something that's clear full of them. I don't know, there's probably 50 or 100 in there. Yeah. Yeah, a couple of each size is kind of what they do.
You tap it in. What?
I was too long.
Oh, no, you gotta be less long-winded,
I'll
man.
be less long-winded. Yeah,
Yeah, there you go. Oh, nice.
there we go. What were you asking?
What secures it to the bone?
So on that one, there's different techniques. So the earlier ones had a keel, so like on a sailboat, a big keel, and you'd cut a keel, cut the cut into the vertebral body at the midline, and then that would secure it. These now just have little tiny teeth on them, and then the disc space, again, there's different brands for a reason, and they have different shapes, but the end plates are pretty much concave, unless they're severely degenerative, but most of them are concave, and so just that shape captures it. So it's titanium with some teeth in it so it doesn't get spit out, and then the poly that's in between them, and the poly is attached usually to one of the two end plates, so it can't go anywhere.
So it's
Plasma
actually
spray, where you get bone ingrowth every time.
Say that?
There's a plasma spray.
Yeah.
almost
Yeah.
Yeah, there's a rough surface that bone can grow into.
So the titanium surfaces, there's all kinds of things, but there's HA coated ones, there's plasma sprayed ones, there's laser etched ones, there's all kinds of things that you do to the surface of the titanium, because bone just loves titanium. I mean, it grows to it really well. And so then you get that bony ingrowth. But I just restrict these people for a couple of weeks, really just for comfort. And I let them use it, pretty quick. Very different than a fusion where you're trying to wait for that bone to heal before you let them move too much. So, but
PT in this person would be, you want to wait a couple weeks before if they want to do physical therapy?
yeah, I usually wait until I see them back at 2 weeks post-op and send them to therapy that day. It's kind of the routine, but quite honestly, I'd be comfortable in that patient, send them the day of. I really haven't had any problems with these migrating, spitting out. I've seen one spit out, different brand, but it was after a car accident. Whiplash injury, and it spit out anteriorly. So, what are you going to do? So they're pretty stable and pretty secure, even from the get-go before that bony ingrowth that Ken was talking about happens. So lumbar spine, again, this is exactly the same procedure, it's just a little different approach. Now I have to share my fees with a general surgeon.
Kind of a quick
Yeah, yeah.
So this is a good example, and I'm sure you did this earlier because it's a good quality.
Yeah.
You betcha.
Your modic end plate changes there?
I just want to point out the modic changes to those. You're like, what are modic changes? If you go to, right there.
There and there.
Okay, that was,
Yeah.
that swelling into the bone.
So I tell all my patients that it's bruised.
Yeah.
It's easier to say that, but yeah. So modic end plate changes they can be very painful. Way back when, I don't know how many years ago I quit doing it, but we would do injections into the disc space, fill it with fluid to see how much pain the disc itself was causing. But I think people caught on that if you squirt that fluid in really fast, everybody hurts. And if you go really slow, nobody hurts. So it wasn't really a very predictive test, but kind of some old school stuff there. But that's kind of where I was, 23 years ago, trying to decide if that is causing pain or not. But in my opinion, if your back has that much modic end plate change in it, it's probably painful. I'm pretty comfortable saying that to everybody. So, and then this one's got, this that we're going to ignore, a little annular tear. Those can be painful too. So when you're sitting in front of the patient, you have to talk about these things. So this patient's a candidate for, you could argue for a fusion. I haven't shown you the facets and stuff yet, but you could argue for a fusion because that's pretty collapsed. And when you do a fusion, you jack that disc space open and you get some good foraminal relief. If you go in and just do a decompression on that, you can get it done. But if they're having a lot of back pain with it, the decompression might not help that. And then also, if you do a decompression on that, you're going to have to take out a lot of the facet just because it's so collapsed just to get the foramen open. And so by the time you do all of that, they might become unstable. So there's lots of things that we're kind of thinking about trying to decide between a disc replacement and a fusion. And quite honestly, the patients drive a lot of this conversation because everybody has access to the internet except this clinic. So I had to. I just had to.
Loved it. That was perfect. Received and enjoyed.
So, disc herniation here. Facets are arthritic. They're not terrible, but they're definitely some arthritis there. So the conversation is, I can do a laminectomy or a foraminotomy or something and probably get rid of your nerve pain, but it might make you unstable, and I might not do much for your back pain. I'll do some for your back pain, but maybe not as much. We can fuse it. You're going to lose motion. It does stress the adjacent levels. We all know that. Although I would argue pretty aggressively that if you look at the studies, fusions aren't as bad as we would like to think they are. They're pretty good if you get the alignment of the spine pretty good. So the alignment of the spine, we have an EOS scanner over at St. Mark's now, which does all the alignment measurements. Super cool. If you have anybody that, you guys should buy one. But if you have anybody that you're worried about alignment issues on, it's a great, great tool. So AI does all the measurements. So you get a report with, an X-ray AP lateral. It's a full body, head to toe, hip and knee alignments. Guys love it for that too. And then you get a report you get the images and you get a report that says my pelvic index is this. So the big issue is if you're walking around too kyphotic all the time. So if your pelvis is tilted forward compared to the average person, you're gonna have to have more lumbar lordosis to make up for that. If your pelvis is more straight up and down, you don't need as much lumbar lordosis, but the goal is to keep this body weight over your pelvis. So a lot of fusions, especially early on in the minimally invasive fusion days, a lot of people got fused in kyphosis, and then that kind of became a big problem. So if you're fused kyphotic, if you're outside of 10 degrees, we call it the pelvic mismatch. So it's the difference, just what I was talking about, the lumbar lordosis and how much and where your pelvis is tilted. So if you look at that and you get them within 10 degrees plus and minus perfect, the chance for an adjacent level wearing out, you get about 20 years out of a surgery before the adjacent level wears out. If you don't do that, you get 3 to 5 years and you're 10 times more likely to have the adjacent level done. So the alignment with a fusion is a big deal, okay? Less of a big deal with this because we're not treating patients with big alignment deformities with a disc replacement. And also this doesn't stress them, I don't think, the same way that a fusion does because it's moving. So it's not, if I fuse those two levels, that guy up there is going to be under a lot more stress than if I do a disc replacement of those two levels. So even if I get the alignment perfect either way, I would make that argument. But
So that the EOS, that's the hospital owns that, or is that
the hospital owns it. Yeah. Yeah. So it's just at St. Mark's, and it's just in the radiology department. Yeah. Yeah. They bought it. Yeah, so it's been there for probably 6 months or 9 months now, something like that.
Internet for that conversation. See, that was here. You found that out. Google that.
And right now, I wished I had bought it because the hospital is very happy. It makes them a lot of money. Yeah, but it's really cool because back in the day, we'd get an AP lateral X-ray, some flex extension films. We'd get our little ruler or a goniometer and our marking pen, and we'd start trying to figure all this out. And now it's just pops up in my medical record with a report.
Less radiation.
Much less radiation. So you get the whole X-ray with a lot less radiation, and the images are crystal clear. And the measurements are better.
CT or series?
Regular X-ray. Yeah.
Would you still get a Flex X series?
I do.
Okay.
Yeah. This is a weight-bearing film. They're standing up, but yeah, and you can do Flex X in it, but it's kind of awkward. Basically, it's a big, it's the size of this corner of this room, and you step on, maybe not that big, you step up on a platform, and then it scans you, and it's only, I think it's 30 seconds or something less than that. Sorry. I got it.
Touch the mouse.
Touch it really fast.
Just the touchpad.
I've got a question for you.
Yeah.
Knowing the world that I come from is
Yeah.
from the reps side of this. If you're doing a disc replacement, there's no stabilization necessarily to that forward flexion. So if there's motor change in there and there's pain on that forward flexion, is there still value?
My argument would be, yeah. So are you talking about doing
burning a nerve in the bone there?
Yeah.
Basic tube.
I think there would be early on, but I think once you do the disc replacement over time, that those modic changes go away. So if you look at an MRI scan of a patient that's had a disc replacement a couple of years earlier, those modic changes do heal and go away because they're not continuing under that stress. But yeah, early on, it does make sense to, I mean, I would think it would make sense.
Well, no, because I look at that image that you had up there before.
Yeah.
Oftentimes, that's the traditional patient we would be burning the nerve
Yeah.
first, but the disc height's still lost.
Yeah.
So if you burn the nerve first, then came back into the disc replacement, is there value and benefit there, or are you saying the disc replacement would take care of it?
I think the disc replacement takes care of it. I just think that the disc replacement takes a little bit longer to take care of the sort of the modic kind of pain. I mean, the nerve pain and all that's gone right away because we've opened that foramen
That's
up.
always been my fear, is the disc height's still lost, so it's probably just a matter of time before stenosis and other things
Yeah.
happen more posteriorly.
Yeah, yeah. And so, yeah, and then with the disc replacement, this is a pro disc. This is kind of old school. Here, you can see the keels on this one. So they used to have keels like that in the cervical spine. They're probably not, I don't think they're necessary at all in the cervical spine. And when you start doing keel cuts and stuff, it gets a little bit more technical. It takes time, and if you don't need them, why have them? In the lumbar spine, we're not quite as confident that these things stay in place as well because it's under a lot more stress. And so most of them have better fixation in the lumbar spine than they would in the cervical spine. But if you do keels like that in the neck, those early on ones were some of the ones that would fuse because now you've cut this big cut through the bone and there's some bleeding and you have taken down the ligament in the front. It starts to heal up and the damn thing gets covered with bone. So I don't like keel cuts in the neck, but I'm fine with them in the low back. Low back's hard enough to get fused when you're trying, let alone with a disc replacement.
So to get the lordosis, do you have different spacing, different?
So we have different widths, different heights, different depths as well. And then the same thing applies. You're trying to get that center of rotation kind of where you want it. But the idea here again is open up that foramen, decompress it. So yeah, I mean that's kind of the ultimate goal. But I don't even know if I answered your question. I've been rambling. So yeah. So with these we don't. They have a little lordosis built into them, but it's not like I can say I want a 10 degree or a 20 degree. It is what it is. Yeah. And each company's, they're all pretty similar, but there are some differences there too. Some patients like this, if you were to do a disc replacement in a completely flat disc space like that, there's a couple of brands that just work much better when you don't have any concavity there. They're just easier to get in, especially down at 5'1". And so, I've done some 3-4 disc replacements, but insurance doesn't pay for those either. So for us, it's 4'5", 5'1". Yeah.
Are those getting easier to get approval?
No, they got easy for a while. Now they're getting hard again. But now I have to do a peer-to-peer to get an MRI scan half the time. So everything's harder. Yeah. But overall, I'd say better than it used to be, but still they got a long way to go. I had one denied maybe 2 months ago because it's experimental after 25 years of literature. So, yeah.
All anterior approach?
All anterior approach. So I was kind of joking about, I have, I don't know if any of you know Chris Mitchell. He's a trauma guy over at St. Mark's. He's kind of the all go-to guy for everything. So I had a near-death experience. He was the guy that when I woke up from almost bleeding out, I had a hernia repair, and long story short, I went back to work, 2 weeks later or something like that, 2 days later, whatever. And I tore the patch, and it tore a vessel. I did my day's work. I felt great. I went home, and I was sitting at the kitchen having dinner, and I said, I just don't feel right. Didn't make it to the sofa, and I hit the ground. Woke up in the ambulance. So, and I'd lost 3 liters of blood from pulling that patch off. So I wake up in the back of the ambulance. It just so happens that the ambulance guy is somebody that I ski with. So he was sitting in the back with me. Couldn't get IVs. I got all the way to the hospital with no IV. But I got my phone from him and I called Chris Mitchell. So that's how much I respect this guy. So he does the anterior exposure. And so he comes in, he does them all retroperitoneal, which is very helpful if you can stay out of the abdomen. Very good at it. We do a lot of them just a little off to the side, some fan and steel incisions. His favorite go-to is kind of this incision. And he does all the A-lifts and stuff for me too. So he's just very gifted that way. The big concern we're doing this now as compared to the neck is the iliac veins, especially at 4-5. They're right in the way. There's a lot of degenerative change. They're going to be stuck down from all the inflammation. So they're kind of hard to move. So the big risk here is an iliac vein tear. And these guys, he's great. We get one every once in a while. It's pretty rare, but that's what he does for a living, is sews them back together. So he's pretty good and don't lose a lot of blood. These we do when the coding allows us, when insurance companies allow us, we could do these as an outpatient too. The big concern with doing them as an outpatient is you've got to be prepared for that disastrous iliac vein tear. So it's kind of hard to get an outpatient center set up for that. But if you're doing enough of them, we can certainly do it as an outpatient. I'd say probably, I don't know, 70, 80% of the, especially the 5-1 disc replacements, we do go home a few hours later. But we do them in the main hospital mainly because of that iliac vein issue. So,
Any data on adjacent level challenges or complications post?
yeah, so the adjacent level problem is not as big of a deal with the disc replacement, but I think again, it's such a complicated topic because I think a lot of that's alignment. They're not getting the same, if they had a big alignment issue, we probably would correct that with a fusion, not a disc replacement. So, but I do think the adjacent level issue is much less of a concern with a disc replacement. I don't know, Ken, if you agree, but yeah. So anyway, he does that incision, gets me down there. Essentially, you just take the retroperitoneal contents, pull it over to the side. We're looking straight on at it. Can I swear? I bitch at him for not giving me enough exposure. He bitches at me for getting too close to the iliac veins. We have a good time. Take out the entire disc, choose the size, put some trials in. A lot of times these, especially like when they're as bad as this 5-1 was, we have some devices to get in the disc space to kind of crank it open to get it to pop. A lot of the time in the back, you can't get the disc height back to where you want it. And then all of a sudden it kind of all pops, all the scarring and ligament pops, and then it goes back to where you want it to, so you can get a disc replacement in there. So, there's a few more technical challenges with the lumbar disc than a cervical disc, but essentially they're the same thing. Very, very, very similar. Oh, look, it's working. So that's just one of the trials. That's how this is, again, the Pro Disc. So you do the discectomy, you seat this in here. You can choose different sizes. You see that this little thing prevents you from pushing it back into the fecal sac. And then that's the guide for the keel cut. And then you do the keel cut, which is just a chisel. And then this is the assembly of the implant. Goes in like that without the poly. So this one we put the poly in after. So, and believe it or not, it's kind of hard to find that keel cut sometimes, the bottom of the big patient. And then this poly then gets forced down in there. And then it's got a little lip on it that locks in once it gets fully seated so it doesn't back out. And this has been a very successful design, but it is a pretty old school design. This is one of the kind of earlier successful disc replacements.
Is that the view you get to have when you're doing the surgery?
Yeah, exactly that. Yeah, exactly that.
That looks easy.
Yeah. And then if I'm honest, that inserter doesn't come off that easy either. That thing can be annoying as hell. But so anyway, that's the procedure itself there. It's pretty simple. Again, patient selection is the big deal there.
Not the, poly, that new kind of mid-disc area. What is that made out of? It's not titanium, that's like a
So-
polymer.
Yeah, so titanium, and then what's it called? Help me out. My mind's blank.
Well, those are cobalt chrome,
Yeah, these are cobalt chrome. So cobalt chrome,
and it's high molecular.
and then the polyethylene, the high molecular weight polyethylene. It's a hip joint cup inside of a cobalt chrome sandwich.
And
So-
the life of that moving piece is what, you said 10 to 20 years?
No, I think the moving piece here, these, because they don't move the same as like a hip or a knee, there's not as much motion there. They seem to last just forever. I've had to revise some for different reasons, but not because the poly wore out. I've never seen that. And the conversation is, they cycle them for whatever 10 million cycles on a machine, and these things just don't really wear out. It's really not a big deal. It's not like a hip or something where you're worried about poly debris and all that stuff. That just doesn't really happen here. There was some conversations about it early on, but I haven't seen or read anything about that for a long time. So, and then you guys know this stuff. This is for a different crowd. So that's kind of what we love to do. I love disc replacements. I still do everything. So I do scoliofusions. We do microdiscectomies. I'm a big fan of the Barricade device. I don't know if you've used that, but so the Barricade, we've been frustrated forever because you do a microdiscectomy and the biggest problem is recurrence. And so the Barricade device is just a little titanium. It's a titanium kind of a keel, basically. Yeah, and then a nitinol spring, and then a little polyester bag that sits on that nitinol spring. You pound it in the disc space, it opens up, and then it prevents anything from coming through the annular defect.
So you place the disc, and you basically just put like a.
Yeah, well, this is for microdiscectomy. So you take out the herniated disc, and then you just put a plug in the hole. We've just never had a plug before.
So is that a common practice, or is that?
No, it's fairly new. It's pretty hard to get insurances to pay for it. Like it's on, Medicare approved it and all that. So, but for the patients that need it, if you're taking care of the classic one would be a big disc herniation in an obese patient that's young. And so you're really concerned about a reherniation. So it's a great little toy for that, just to plug that hole. But again, getting the insurances to pay for that.
I've had this question a lot actually, because we see this in our clinic.
Yeah.
Still out of pain, doc, what's hurting? I don't know, it sounds like you're hurting the disc. So if you don't have insurance pay for that, so what do you do to prevent a recurrence of the disc herniating? Is there anything, you sew it up differently, or do you?
Harp at the patient nonstop. So in the past, we had some special suture kits where you could try to close that annular defect, and they tended to cause a lot more post-op radiculopathy as they got resorbed and everything. And so those kind of went out of favor because they probably did help contain some of the disc, but they weren't great closures anyway. And so if I can't use that device, it's really, I put them in a brace and I tell them to be careful, and I make them be really careful for 6 weeks. And too many of them still reherniate. Yeah.
The defect on that has to be big enough for that Barricade system to get in there, otherwise.
Yeah, it's a very specific size defect. If it's too big, they're not wide enough to cover the defect. And if they're too small, the recurrence rate's low, so you don't really probably need it. But yeah, so a defect that's like, so essentially you need about 4 millimeters of disc height to get the device in, and then between 4 and 10 wide. If it's wider than 10, you're probably not going to be preventing disc herniation. So they've got some parameters around it, but again, because of the study.
I was involved with, the other closure devices.
Yeah.
To kind of close the annulus, but then the frustrating part is you never know what the consistency of the annulus is.
Yeah, yeah.
Whether you have something that can close.
Yeah.
You have to use a smaller discectomy so you can close it. The annular opening has to be very limited.
Yeah, yeah.
Yes,
So it's just I've honestly never had much success trying to close them until we got this. Yeah.
It's called a Barricade device.
Barricade. Yeah. Kind of a cool little device. So do a lot of microdiscectomies. I try to use that when I'm allowed. We do, all the standard fusion stuff. The only thing I don't really do is tumor work. Haven't done that for probably a decade now, and it's a good thing to not be doing that stuff. Yeah.
Surgery, how often do you, I guess, as a therapist too, do you send someone like prehab? Like if you know that their dynamics are off, like would you, hey, let's see if we can prehab them, get their hips more in line prior to surgery? Is that something you have done? Steve, have you seen that before?
I send actually, almost every insurance company outside of straight up Medicare requires therapy before we even talk about surgery. So they kind of have to fail it. So all that nowadays gets done beforehand. The problem with that is, anytime you write a policy, right, it applies to some, but not all. And so you get these big, fat, juicy disc herniations, and they can't even walk in the office, and therapy's not going to help, but they still have to go. And so insurance companies will let the therapist say, I can't help them, but the therapist has to say that. I can't say that. So if the therapist says, no, he's in too much pain and he's been here for 2 sessions and I'm making him worse, then they might let him out of that. But most of the time, we have to do 6 weeks of therapy
I've
first.
seen Steve work, and there's no patient he can't hear.
Not true.
Yeah, yeah.
What's the time frame after the lumbar's done for PT?
Afterwards, so in a disc replacement,
So with the neck, sometimes they can go right away,
yeah,
but here we're dealing with.
Here-
Bearing.
I'm still pretty comfortable with these, but I start PT about the same time frame. But the PT at 2 weeks is pretty tame, and then I turn them loose at 6 weeks. Yeah, so we ask the therapist in the first couple weeks to just kind of take it easy, make sure they're moving, you know. And a lot of that's the abdominal incision too. We don't want to tear that apart. But I've never had one of these spit out either, so they're pretty stable right away. The poly locks in really nice and tight, so yeah, I haven't had really much problem with that at all. So, all right, other questions? That help? Make sense?
Dr.
Yeah.
I really appreciate you taking time to come and sharing that with us.
Yeah,
I said, if anybody does want barricading contact information, we have it.
yeah, yeah, yeah.
You can reach out to you.
Yeah, I did not do, I was going to do this study, but it was while I was employed, and PSG would not let me. So, too many hoops to jump through, so we didn't do it with them. But I am a big believer. But yeah, and they get your approvals and all that stuff for you. So, yeah, it's a pretty great idea.
Tell us just a little bit about your change.
Hi, by the way.
Thank you. Tell us a little bit more about your change. You left employment by.
Yeah, so well, I mean, part of that story. I was there with Born and Mariana and those guys for 18 plus years. And then when they wanted to go kind of part-time, that's kind of impossible to do. So we worked for a couple of years trying to get them to each go half-time, but they wanted to be together half the time they were vacationing. So none of that worked out. So they finally convinced us, and I have a ton of respect for those guys. I mean, they set up a really nice clinic, and I was very much a beneficiary of that. So, so we finally agreed to sell so that they could both go part-time. So they both went part-time. Made it about a year, and then they both retired, and then they both came back a couple months later, and then a year later they fully retired, and then a year later I got the heck out of there and went back into private practice. Yeah, and that's like when you're in private practice for a lengthy period of time, it's hard to now be employed. So I joked earlier before we got here that I was a terrible employee, but they were pretty bad administrators too, so it just didn't work for me. Some of the younger guys love it. You just go home and get a paycheck at the end of the month, but I need to be more involved in
Who's
that.
covering for you when you need to step away?
So my
Chase obviously is there.
yeah, so Chase, I don't know if you've ever met Christy Christensen. She ran the comprehensive spine clinic over there for us. So she's now with me, and then I've got another nurse practitioner, and then Pingree primarily. Whenever I'm leaving town this weekend, Pingree's covering for me. And Pingree now, he did the same pathway I did, but then he joined the Intermountain Group. Yeah, and he's not happy about it yet, because he's back to paying overhead.
Does Chuck still send anybody up, or with his arrangement with the hospital?
Yeah. Chuck. So I stole Christy, and I didn't steal Christy without talking to Chuck first. Yeah, I'm not that dumb. So yeah, I set that clinic up for the hospital probably 20 years ago, just to get patients to be able to be seen immediately with Ryan Church. And so Ryan did it, and then we had a couple people in between, and then Chuck's been there, and Chuck's just fantastic, so he's great. And there wasn't enough volume for the two of them. So he was happy to have Christy come upstairs. So we do everything we can to not compete with him. Yeah. And he sends me, 1 or 2 a week, something like that. Yeah. All right, well, anything I can do for you, let me know.
So last question, sorry. So now that you're private, are you handled on Select Health as well as everything else? Or
No, the only one I'm not on is Select Health now. Yeah. And it's just because I don't want to have to go to, I'm busy not going to another facility. So I go to 2 surgery centers and the hospital. So, yeah. So anything but Select Health. Well, thanks for having me. Appreciate it, man. Yeah.